Good evening, everyone, to the Yashoda Hospitals webinar series on emergency medicine. Every week, we'll be bringing up all the important relevant topics to the emergency medicine. This week, we'll be discussing about the MRCEM OSCE, what it is and how to approach your stations and all. If you have cleared your MRCEM primary and intermediate, the next step, the final one to clear is MRCEM OSCE. So once you clear this, you'll be given the MRCEM degree. And if you want to get notified about our weekly webinars, you can actually visit this address on Telegram. Search for MedMeet. You will find a channel. You can subscribe to it. So the OSCE stands for Objective Structured Clinical Examination in short. So you will be tested on your clinical skills while an examiner is observing you. So during COVID, this was in fact done like a hybrid model where some of the stations were taken via a video conference, while some stations which actually require you to touch the patient, that is examination and procedures, they were done offline. The online stations were relevant to history taking, conflict resolution, communication related stations, which don't involve touching a patient, were actually done online. But now everything is offline. So, but both options are available. If you have had any USMLE step 2 CS exposure during your preparation for USMLE or something, you will feel that very much familiar to step 2 CS and OSCE, both are similar. So it is going to test your clinical and communication skills. So both adult and pediatric patient set will be available during stations. In the pediatric, they expect you to manage a seriously ill and injured child and also some of the common childhood emergencies. So you'll be given 6 attempts to clear the exam. So those 6 attempts will be counted if you have given 1 attempt at this OSCE exam after August 2016. Before that, they won't be counted. So out of all 16 stations, each one will have 8 minutes of duration, and between the stations, you will get 1 minute to read the scenario. And apart from these 16 stations, you will also have 2 rest stations. So each station is scored at 10 marks each. So total, you will have 160 marks of exam. So 16 stations, 8 minutes per station, and 1 minute break before the actual station. During this 1 minute, you are supposed to read the question, understand, and make a plan on how to approach that particular station. So these 18 stations will be spanned across like a circuit. So some of them will start at 1, the other candidate will start at 2, 3, 4, like that. Among these 9 stations, 1 will be rest station. So this rest station can come to you in the beginning or at the ending or in the middle. Say you are the 4th candidate, you will be obviously starting with rest stations. So once you start with the rest station, you will have to finish 8 stations before you get another rest station. If someone has started at 1, after 3, he will face the rest station, and after that, he will face 5 more stations. And in the second circuit also, it will continue the same. So I have given you a circuit of 9 stations here, but if there are enough resources available, sometimes they will keep 18 stations at stretch. In that, 2 will be rest stations. So either 2 sets of 9 stations or 1 set of 18 stations will be arranged based on how many examiners and how much of infrastructure is available at the exam venue. So in each station, they can test multiple domains. So the domains are clinical reason and decision making, your communication skills, including conflict, history taking and information gathering, clinical examination skills, practical pinnacle skills, teaching skills, organization, and prioritization. Of these 7 skills, each station might test at least 2 to 4 domains. So in each station, each domain will carry up to 5 marks. Sorry, means starting 0 at 4 marks. So 0, 1, 2, 3, 4, based on how you perform. So your performance will be based on your either they will check your competence, knowledge and skills, errors you are doing during the task, and how complete your task is. So if your competence is well below the minimum, you will get a 0. Below minimum level is 1. Minimum level of competence, if you show it, it is 2, and above minimum is 3. Well above the level of minimum competence is 4. Coming to skills, if you have above the minimum level of skills, that is 4. Above minimum level of knowledge or skills, that is 3, and minimum level is 2. Below minimum is 1. Very poor level is 0. If you do frequent minor errors, you will get 0. Infrequent minor errors, that is 1. Minor errors, they are identified and rectified by the candidates themselves, they get 2. Single minor error identified and corrected is 3. No errors, 4. Coming to task, if you have not completed, you will get a 0 on this. If you have completed but with poor standards, you will get 1. You have completed satisfactorily, 2. With good standards, 3. With high standard, it will be 4. So this way, your performance will be scored. So as I told you, each question, that is each station, might have multiple domains that get tested simultaneously. So not just the clinical skills, the communication skills, your prioritization, everything will be tested in a single station. So it's one station, but multiple domains that get tested. Coming to the distribution of stations, so there will be 3 stations on complex stable patient, that is specialty learning outcomes 1 related, and 2 stations to answer the questions, 2 stations for resuscitation, 2 stations for treating an injured patient, that is trauma, 1 station for pediatric emergency medicine specifics, and 2 stations for procedural skills, 2 for complex challenging situations, and 2 for supervise and teach. Though this is like a rough guide from the RCM, sometimes they may mix and match. Say they can give a pediatric patient that involves resuscitation. So that can be counted either as resus or pediatric emergency medicine. So this is just to give you a rough idea. They need not stick to actual distribution. So whenever you approach a particular station, first understand what the question is asking, what you are expected to do in that station. So you will have a pie chart. So that pie chart should be taken a closer look. With that, you will understand in which domain you get tested more. So though each station is going to test on multiple domains, not all domains will carry the same weightage. So some of the teaching stations, they might carry more weightage to actual your communication skills with your student than your any examination. So look at how much percentage is given to each domain, and then based on that you perform. Say you've been through one of the stations and you did not do well. So what to do after you come out of the station? Don't worry about the previous station, because no matter how much you think and how much you want to correct now, there's nothing you can do. And we have seen some candidates who rush to the previous station and start yelling, shouting there some of the answers. Sir, I forgot this thing in the last station. So they are trying to make up for the mistakes they did, but once the scoring has been done, there's nothing the examiners can change. As of now, the scoring is fully done on iPads. Each examiner will be given an iPad. In that, they'll be scoring it. So don't worry about the previous station. because if you keep thinking about the last station, you only have 1 minute to read and understand the next station. So that station will also be affected and it will result in a continuous cycle. Bad station, bad mood, another bad station, another bad mood, like that. So your entire performance and exam result will be in a bad state. So don't ever think about the previous station, and gather what's been asked in the question paper. So look at the question paper and plan what to do in the next 8 minutes. So that 1 minute, you may not require 1 minute to read the question, but in 10-15 seconds, you will be done with your reading part. Then rest of the time, you will have to actually plan out on how you are going to approach your station. So once the timer starts for the station, knock the door. Just because the door is open doesn't mean you can just jump in. So it's good manners to actually knock the door. Then introduce yourself, confirm the patient ID, age, and also when you are greeting, you can greet the examiner. So they're not very particular about greeting the examiner, but you should greet the patient. So make sure you identify the patient with their name and age. So is it Mr. John, 30 years, male? Is that so? I have the notes that says your name is John, 30 years. Do you confirm? So like that, you can verify whether you're in the right room. And then ask if they're comfortable. Some of them may not be comfortable around you. They might want some family member or friend to be along with them. So you have to ask them, do you need someone chaperone? Or if you are in pain, I would like to offer you a painkiller. So most of the times you will get no to these answers, to this question, but still you have to ask. And before entering, during your entrance itself, you can sanitize the hands. So if there is a hand wash arranged, you can do that, or you can go with alcohol rub. So if it's only a history taking station, this may not be of much importance, but making it a habit will make sure that you don't forget this step during actual stations. So let's look at some station specific slides, that is history taking. So when you have such history taking, this is one of the sample questions that we have framed for the mock exams that we conduct. A 45-year-old male with a history of recurrent unilateral headaches presents to the ED. Take a detailed history. So in this, if you can see, there is 50% weightage to the history part and 50% to the clinical knowledge. That means based on how you take the history, you get 50% in an order, and based on how relevant your questions are and what you're trying to elicit, that shows your clinical knowledge. So based on that, your history and clinical knowledge will get marks. So establish what you're trying to elicit with each question. So don't just randomly ask just because it was there in the checklist of your OSCE textbooks. So you have to be very much human sounding. Don't just like, do you have any pain? Do you have allergies? Do you have medications? Don't go with this robotic manner. So you have to be calm. Your confidence should be visible. And when your patient or subject is talking, do not ever interrupt. So you have to let them finish. And ask for, in any history, you will be going through the sample history. That is signs and symptoms, allergies, medications, last medical history, last oral intake, or in case of females, you can ask about the menstrual cycle if that's relevant to current presentation. Events leading up to the present illness or injury. Ask relevant family history and social, personal history, like do they smoke? If so, how much, how many cigarettes per day, and how frequently? And if they have any illicit drug history, do they take alcohol? Travel history is especially useful if you're trying to elicit a DVT or pulmonary embolism case. Their occupation, and that means whether they're working in a sitting ideal position or it involves any recurrent trauma to one of the shoulder joints and all. So their living conditions, all of these things come in the social history. And when it comes to pain, you have to elicit all these things. You can remember it as Socrates. So ask about the site, how it started, and what kind of pain it is. Does it radiate anywhere? And are there any associated symptoms? Like if someone is having a renal colic scenario, they will definitely have nausea or vomiting. Similarly, if it's a chest pain, that is cardiac, they might have radiation and also associated symptoms like sweating. So you have to elicit the relevant Socrates history. So timing, so what is the duration, since when it has started, any exacerbating or relieving factors, and how severe it is. Based on the severity, you may have to think about analgesia. So elaborate on relevant questions. So if someone says that, if you ask about the occupation, if he says that he's some clerical guy, that means he's going to sit and work. So in that case, you have to elaborate. How long do you sit? Does he take any breaks during the job hours? So those relevant questions should be elaborated on. And once you're done with your history taking, you must thank the patient and then summarize to the examiner what you gathered and offer any DDs based on the history you have collected. And sometimes you may not be able to diagnose the patient based on just the history taking. So you would want to run some tests. So tell the examiner that I would like to run these tests to establish the diagnosis. If you're trying to elicit, say, if you're trying to elicit someone is having a pulmonary embolism, in that case, what do you like to do? So whether you want to do a D-dimer test or CT pulmonary angio like that, you will have to lay out a treatment plan. So based on that, the examiner will know that you have the relevant knowledge. So that way you will get the marks. If you notice this question answer template that is given to the examiner. So in this, you have the domains, 2 domains that are getting tested with equal weightage for both. So one is history taking. So introduce yourself, then sample history, whether it's taken, Socrates, associated features, triggers, whether the candidate has asked the subject or not, they're going to see. Based on that, they'll simply put 1 score. So high competence or well below the competence. If you're somewhere between, they'll give 2 or 3 marks. Similarly with the clinical knowledge. So this answer sheet was given for headache. So that was, so in this case, you have to consider trigeminal neuralgia as one of the differentials, and CT or MRI is not required in that. So neuro follow-up is required. So whether you say the word neuro follow-up and or not in the plan, that is going to affect your score. So the examiner will enter some comments to justify what score he has given, whether he has clearly marked you as pass or fail. That kind of justification is given here. So the global judgment will go here. So scoring and global judgment, and they will sign off, and you will move to the next station, and the examiner will move to the other candidates. When it's related to examination, so even those stations will have multiple domains. So for example, examination of abdomen was asked in one station. So in that, clinical skills have 80%, means how well you are going. So introduction, patient ID, consent, Socrates history, associated features, any positioning that changes the pain, exposing the patient properly, and also examining the hands, head, neck, inspection for scars or swellings, palpation with deep breath, during that, you have to look at the patient's face to check wincing, check liver and spleen borders, lymph nodes, hernial sites, percussion, and auscultation should be done. Even if you don't do it, to complete the examination, I would like to do a per rectal examination. Just mention it. So if you miss any of these things, your score will be hampered. So your score will come down. Similarly, during your examination, how well your behavior is with the subject, that is going to be checked. So whether you're asking for permission from the patient. So just because he's lying down with the abdomen exposed, you can't just go in directly with the palpation. So tell them you're going to touch the patient. If you experience any pain and all, I would like to stop. Ask me to stop. You can say that. So take permission. Explain all along what you're going to do, why you're pressing. You can just explain it. So that way, the subject knows what you're going to do, and also the examiner will be aware that you are doing relevant thing. So tell patient to express if examination is painful, offer DDs, and explains the need for any ultrasound, X-ray, or ECG in that particular patient. So this is how you should be approaching an examination station. So this is where we post our weekly webinars on Telegram. You can just visit telegram.me/med_meet, or simply search for medmeet on Telegram. Next station that is important one is research skills. Your resuscitation skills are important. These are the ones that actually tell you that you are an emergency physician. So you have 2 resuscitations. So among the 2, you must clear at least 1 station. If you fail both resuscitations and you clear rest of the 14 stations, you will be failed. So 1 resuscitation at least should be clear. So expectations are higher than other stations. Means in other stations, even if you do 270 or 80% of scoring, they might take it easy. But in resuscitations, they will expect you to perform 90% or more. So you don't have any scope for mistakes during the resuscitations, because ACLS, BLS, PALS, ITLS, all these things we do day in and day out in the ED. So make sure you don't do any mistakes in those stations. So history. During this station, history doesn't have a priority, because the station will be explained to you during the 1-minute break. So the question itself will have some history that is needed for you. For example, this is a ACLS station that was given in a CKD patient. So in the question, we have given that you just received a patient in an unconscious state, and you remember that you have recognized that patient because that patient comes to your hospital every alternate day, and that patient greets you in the parking lot. That means they come to the hospital every alternate day and on the same time. So what kind of patients come to hospital at the same sessions? So that means we were indirectly giving a hint that that's a dialysis patient. So in dialysis patient, the cardiac arrest, what do you rule out? You have to rule out hyperkalemia. So in that case, the history is only relevant to, you can ask whether the patient has missed any dialysis sessions. So this resuscitation can be PALS, ATLS, or ACLS. So ATLS can be there in trauma or also in resuscitation. So whether you follow UK ALS guidelines or USA ACLS guidelines, it doesn't matter. But if you are able to do, please follow the UK guidelines, because your examiners will mostly may not be always from the UK. So they can either be practicing ALS or ACLS. So even if you answer in both the algorithms, they will give you marks. but your drug doses should be full. Don't just say epinephrine, say epinephrine 1 mg, 1 milligram IV. So that's how you can say during cardiac arrest, you are supposed to dilute it. So 1 in 10,000 dilution, you should say. So epinephrine 1 mg, 1 in 10,000 dilution, let's push IV. And frequency, how frequent you want that to be. Every 3 to 5 minutes, you can say, you can make use of your team. Your team attitude is also important in this. So if you're defibrillating, you have to mention the joules. Don't just say synchronized cardioversion, and you have to mention in synchronized cardioversion, remember UK and US energy is very much different. And when you're defibrillating, safe defibrillation is very much important. So make sure, even if it's a dummy defibrillator or if you're acting, make sure you say clear before pressing the shock button. Don't think that you don't have a team, you're the only one who is. Sometimes if you don't have any team and if you're doing defibrillation, as there are no people around you, you might think there is no point in saying safe, saying clear, because you are the only one. But the examiner might not like that. So you have to say clear and then defibrillate. You must follow proper sequence of ACLS algorithm. Just because 5H and 5Ts, you know it of to be clear, don't just mention it in the beginning itself. First do a couple of cycles, then think about the reversible causes. So antidotes, for example, in this patient, it was a CKD patient with cardiac arrest. So in that case, you have to think about your hyperkalemia measures like calcium, insulin plus 25 dextrose, like that. Or in the history, if they say that the patient was found to have taken some overdose, in that case, you have to give some kind of antidote. Only then you will get the ROSC. So your effective teamwork will be awarded. So communication skills, our team skills, they have 20% scoring. So behaves politely with the staff, checks competence, discusses with ICU or family after ROSC. So just achieving ROSC itself will not end the station, and you have to discuss the post ROSC plan also. So in this case, suspecting the CKD, asking for an ABG, and defibrillating on timely and on safely are important. So your communication skills are also scored in this. So coming to trauma, in ATLS stations, you will have to go in an order. Like you have to mention the primary survey and then secondary survey. So in primary survey, at the end, you have to mention you would like to go ahead with the X-rays and blood tests for the adjuncts of primary survey. So in primary survey, airway, I'm just say to talk to the patient. If he is able to talk, that means airway is clear. So this you need to convey to the examiner. So as the patient is talking, I assume the airway is clear, and let me protect the C-spine based on the trauma scenario. So you have to protect the C-spine. Then I'm checking the breathing and part and start with inspection. So your primary survey should go in an order. As per ATLS, say for example, you have something wrong in the circulation. So after correcting the circulation part, you cannot just go to the disability part. So you have to again start with the ABC. And then exposure environment control. You have to undress the patient, but make sure you don't cause any hypothermia. And once you get the adjuncts, you can go ahead with the secondary survey. That is head to toe examination. And at the end of examination, you can take a proper history. So basic history about how things happen, what happened and all, you can simultaneously do during primary survey, but a detailed history should be done only after your secondary survey is also finished. So especially your mentioning of mass transfusion protocol in case of severe trauma with hypotension is going to carry some marks. So blood products, ideally you have to replace blood products with blood products only. So only when you are awaiting blood products, you can start fluids, but you have to replace with blood immediately. So in this, we had 3 domains that got tested. So decision making, clinical knowledge, and communication are team skills. So again, these skills are similar as per ACLS station. And clinical knowledge, you have to follow ATLS guidelines in order, locate wound, do a refast scan, trauma series imaging, and administration of TET globe. If they give you a devitalized tissue and all, very much tetanus prone injury, you have to consider TET globe. This is going to carry at least 1 mark. So you have to call for backup in the beginning itself, check vitals, history, oxygen plus monitoring, giving fluids with blood products, and tranexamic acid. So these are the things that are important in a trauma station. Next, coming to pediatric emergency medicine. In this, you might have a pediatric cardiac arrest that could be part of either resuscitation or a pediatric one. They can give you routine pediatric presentations like this one we have tested recently on limping child. So in that, how it started and all, that history is important. So history is 50%, clinical knowledge is 30%, your communication skills, whether how you're talking to the parent and they're checking their social circumstances, if they are asking questions, how you are answering them, all those things are important. So history. So limping child, you need to know whether it started suddenly or gradually. So check for any trauma, recent illness, any other systemic symptoms, and any similar episodes, and then a detailed sample history. So anyone coming with pain must be offered analgesia. You have, if it's a child, always rule out non-accidental injury. So mentioning that is important. So asking relevant questions to rule out NAI, check for explain the DDs and need for examination and X-rays, blood tests, and if sometimes they will show you some X-ray. So if you say that I would like to get an X-ray of this part, they will have that image ready. So they might give you the X-ray or show an image. So you need to identify that X-ray. So reading X-rays is also important. Next station will be like practical skills. So in this, they might combine it with teaching while you perform a procedure, and you will be asked to actually teach one of your residents. So for example, if they're trying to place a central line here, so central line is not expected from MRCEM OSCE candidates, but if you're doing some procedure like ABG, you're expected. Taking blood samples, you're expected. Shoulder relocation, you're expected. So these kind of things will be asked. They might ask you to apply a plaster of Paris cast or some Thomas splint application. So these have been asked in the past, so they can be asked again. So we have asked suturing skills in our mock tests. So in that, the practical skills score about 70%, whereas the communication skills are 30%. So in practical skills, when you're going to suture, so you have to make sure you have at the right patient and check their tetanus status. And don't just blindly give TT injections just like that. You should know which kind of wounds would require, and if someone has already fully vaccinated with 5 doses, do they still need tetanus or not? You should know. So check their tetanus status. If the patient requires, then give. And then check for analgesia, any allergies. You should know the equipment. You should maintain your sterile technique. If you are going to give a local anesthesia, so you must check the expiry date. So if your examiners are like me, I've given one expired drug during the mock testing. So, but of course, none of them have actually found it. So that's a sadistic attitude, but still the point is you have to check the local anesthesia expiry. Don't just give it. And once you load the anesthetic, local anesthetic, you should not use the same needle to prick the patient. You should change the needle and use a fresh needle to puncture the patient's skin. Check for flashback, then only give the local anesthetic. Check effect of local anesthesia before suturing. So your local anesthetic is not an instantaneous acting drug. So it will take 3 to 5 minutes. So you have to at least tell them, because you won't be injecting the patient directly. So you will be injecting on some equipment. So suturing equipment and all. In that, just tell that now I'm checking whether the LA has its action now. Now the patient is not feeling any pain. I would like to go ahead with the suturing. So after suturing is done, you have to dress the wound. And during this suturing, your explanation, obtaining consent, maintaining the wound area, how you're approaching to your suturing, how good your suture lines are, how good your knot techniques are. All those things are important. And you have to tell them when to get this suture removed. So sutures, not all will require removal in 5 days. Some will require 1 week, some will require 10 days. So you have to tell them. And how to get help if there is a sign of infection. So to know that, you should tell them how to identify infection. So this is about the complex challenging situations. In complex challenging situation, so these are very difficult to clear. So it's not easy to actually clear these stations. And even if you perform well, by the time you leave the station, you won't be confident that you have done it well. So these are very difficult. So don't worry. So if you say that there is a difficult referral issue, or the patient is not listening to your orders and he's denying some investigation that you think is very much important for the diagnosis. So in that case, you will be asked to go and convince the consultant to either see the patient or convince the patient to get that test done. So before you go, you have to know the issue in full. So don't just jump in. So know the issue in full. If you think that your team has done some mistake, you can apologize. During your encounter, you can be soft spoken, but you have to be firm on what you need. So explain why you are insisting on. Says you're asking the surgeon to come and see the patient. The surgeon says it's not an emergency and he will come in the morning. Now you have to explain why you are insisting, why your expertise is required in this session. So you have to tell them that your expertise is very much important in the best interest of patient, so that we don't miss out on some surgical emergency. So based on the questions scenario, you'll be able to tell the surgeon why you are involving him. So mention relevant guidelines if needed. If they say that it's not an emergency, you can see it the next day. So cite some guidelines. As per these guidelines, you need to, we need to treat this condition within this time frame. Otherwise, there is a risk of limb or life. So in that case, they might be convinced. If you have done everything you could and the consultant is not getting convinced, so your final option will be to, I'm sorry, but I'll have to escalate the issue to actually save the patient. You can say that. So by the end of the session, sometimes you may not be able to convince the consultant, but don't worry about the outcome. How you approach the station is going to decide on the scoring. So your calm professional attitude is going to help you here. So in difficult referral, we have given 75% for communication skills and clinical reasoning. So in such one patient, why a reduction and fixation is needed, and arguments if they are logical, and if the surgeon says something, how you are countering it, your arguments, those things are going to decide the scoring. So when you are approaching the surgeon, your junior might have already spoken to him. So ask the surgeon what he knows already. Tell what's needed from the surgeon. Remain calm and professional. Coherent approach in response to changing discussion. So this is how your communication skills will be tested. So next is supervise and teach. So you will get at least 2 stations that involve actually teaching. So they can combine it with a procedure station where you're doing a procedure and simultaneously teaching the resident, or plain teaching sessions. In that, first, you have to know what the student already knows. Ask them what they know about this. So if it a safe sedation, so how you're giving sedation is going to give you 50% mark, and how you are explaining this to your student or resident is going to give you 50%. So they're testing 2 things here. So every time you tell the resident something, ask them whether they have understood it and if they have any questions about the same thing what you have told. At the end of your teaching session, so during teaching skills, first assess the students' knowledge, invite questions, check their understanding, how to reduce the risk, and your rationale to do this safe sedation, how to manage the post-procedure complications and all, and offer learning resources. Tell some websites or some textbook names at the end. Ask the student to meet at the end of the class to actually get a list of resources. So just one word is enough to cover this aspect. So this is about the teaching station. As I told you, teaching stations might be combined with your clinical skills or practical skills. So these are some of the useful resources. So the official RCM exams website, that is rcm.ac.uk, is going to give you some official information. If you want to watch some videos that to perform OSCE examinations, and through that you can actually copy what they're doing. So that's a very good resource. You can go to Geeky Medics YouTube channel. So search for Geeky Medics on YouTube, you will get it. And if you want to go through the checklists and all, and how to approach each station, this is one of the good books, that is Final OSCE 125 OSCE stations. So this is the textbook form, it is available. And on frcmprep.com, I have posted one blog post about the OSCE. Even that will be informational. So again, you can get to know our future webinar related notifications on this Telegram channel, telegram.me/med_meet. So every week we'll be posting the link, and also this recorded session will be posted in that Telegram channel. If you do have any more questions relevant to MRCEM, residency programs and all, you can connect with me on Telegram. This is my ID, that is Dr. Nims. So you can post your questions there relevant to the MRCEM. Okay, we'll be ending the session now. Thanks for joining.